This is the last voiceover for arterial vascular problems. So we're going to look at aneurysms and dissections. So these vascular problems originate in the aorta. So prior to this, we've talked about problems that originate below the aorta. The aorta, you know, is the largest artery in the body, and it supplies oxygen, nutrients, and blood to all of the vital organs. So these problems are very serious. We'll start talking about aortic aneurysms. So they are permanent localized outpouchings or dilation of the wall of an artery. There are a couple of different forms here. It's not important to know these different classifications. I just offer them to you so you can see how either the artery dilates or it outpouches, and then down below how it can tear and rupture open. These are more common in men, and the incidence increases with age. We're going to talk about abdominal aortic aneurysms and thoracic aneurysms. 3/4 of all aortic aneurysms are abdominal aortic aneurysms, and 1/4 are thoracic. This is a nice visual for you, so you can see a thoracic aortic aneurysm on the left, both an aneurysm and a normal thoracic aorta, and on the right you can see an abdominal aortic aneurysm. So you can see, remember the length of the aorta, how far down it reaches below the kidneys, and you can see the difference in the locations. Now, aortic aneurysms are caused primarily by atherosclerosis, like many of our other arterial problems, and there are some other causes such as congenital problems, mechanical problems, trauma or blunt injury, inflammatory or infectious issues, pregnancy, and graft infection or failure. And here is a picture of a very large abdominal aortic aneurysm. Here are the risk factors. Remember that atherosclerosis is the primary cause. This is the exact same slide we looked at in peripheral arterial disorders. So I'm not going to take a lot of time on this slide. I just placed it here so that you could be reminded that it's similar and what the risk factors are. So let's spend a little time here looking at the two different types of aneurysm and some of the assessment findings or clinical manifestations. So a thoracic aneurysm, actually both of them are often asymptomatic, but findings specific to a thoracic aneurysm involve deep diffuse chest pain that may extend to the scapular area, angina caused by a decreased blood flow to the coronary arteries, a hoarse voice and a brassy cough, which is due to pressure on the larynx from the weight of the aneurysm, dysphagia, difficulty swallowing, and that's due to pressure on the esophagus. And then finally, JVD, edema of the face and arms, stridor, and dyspnea, all as a result of pressure on the vena cava. An abdominal aortic aneurysm may have a pulsating mass that you may palpate in the periumbilical area, so right under the belly button, a little left of midline. Bruit on auscultation, back pain, epigastric discomfort, and even altered bowel elimination may occur related to compression of nerves. These clients sometimes say they feel like their heart is beating in their abdomen when they lie flat on their back. Couple nursing diagnoses that apply here. Ineffective tissue perfusion, and that can be related to that weakened arterial vasculature, and it may be evidenced by weak distal pulses. So here is a time to stop and think about that. So if the aorta is not does not have sufficient vasculature, the blood pumping through it is probably not pumping through effectively, and we're not getting good perfusion distally. Another related diagnosis, not one that was on your objectives, but one I put here just because it relates, is impaired gas exchange related to the pressure from the aneurysm. So this is evidenced by dyspnea and a brassic cough. So here you can see how impaired gas exchange is probably more closely aligned with a thoracic aneurysm, while ineffective tissue perfusion aligns with both of them. So the most serious complication of aortic aneurysms is that they will rupture. That would be characterized by severe back pain and possibly back and flank ecchymosis, which is called Gray-Turner syndrome, and that's the picture on the right. I also included the picture on the left, that's Cullen's sign, and it is possible that that may also be noted. Your text doesn't talk about it, but I included it here just for you to see that. More than 90% of clients die from hemorrhage associated with a rupture, and you can also then understand why they may experience hypovolemic shock. They also can experience right-sided heart failure because of high blood pressure and increased blood volume returning to the right side of the heart from the vena cava can cause that. Immediate surgical repair is necessary if these clients are going to survive the rupture. The nursing interventions that we employ if a rupture occurs is bed rest. We want to look at a semi-Fowler's position, mostly so that we don't put pressure on the aorta itself, also to assist with effective gas exchange. We need a quiet environment. We need to keep the blood pressure down. These medications are not on your objectives list, and you're not responsible for them, but I put them here so you can think about them again. We've looked at these in other classes like shock. So sodium nitroprusside IV would certainly help to bring down that systolic blood pressure. We need to keep it low, between 100 and 120 millimeters of mercury, and of course that makes sense when we're talking about hemorrhaging. We want to keep a close eye on distal circulation, so we're going to do all those things that we do to assess effective tissue perfusion, which there probably will not be because we've got bleeding and from that major artery, and so the blood isn't perfusing to the feet. Frequent neuro checks, including level of consciousness, and of course certainly frequent vital signs. Diagnostically speaking, very often aortic aneurysms are just found by accident when a diagnostic study is being conducted for another reason. So they're often found when a simple chest x-ray or an abdominal x-ray is being done. And I can give you the example of my stepfather, who is an avid hunter, and one day he was up in a tree stand and he fell out of the tree stand and out of the tree, and he had fractured his pelvis in several places, and he was brought in. He actually had a CAT scan done because of the fractures, and when they did it, they found that he had quite a large abdominal aortic aneurysm. And when I talked to him on the phone shortly after the accident, he was pretty annoyed that they had also found this aneurysm, and that after he recovered from his injuries, he was going to have surgery. And I said to him, you don't know how lucky you are, because had this not happened to you, you could have just died in your sleep. That aneurysm could have ruptured, and that would have been that. So very often people don't realize that. A transesophageal echocardiogram often is helpful to locate an aneurysm. An EKG might be done to rule out a cardiac issue, because often there is that chest pain or back pain. The CAT scan is really the most accurate. It really helps to show the location, as does the computed tomography angiography with contrast. You can get a good location and a good size, a good measurement of the aneurysm, and that's important. We'll talk about that in a minute in terms of treatment. If the aneurysm is small, clients will be asked to come back about every 6 months and have a duplex ultrasound to see if it's growing in size. Sometimes with an abdominal aortic aneurysm, you can palpate it, but I put it in red here because you want to be very careful when you palpate that you don't actually rupture. So the goal is obviously that we don't want the aneurysm to rupture, and we want the client to continue having adequate tissue perfusion to distal extremities and also to major organs. So whether it's medical monitoring or surgery really depends on the size and the growth rate of the aneurysm. So typically aneurysms that are 4 to 5.5 centimeters in size are just treated conservatively. Those smaller than that are just watched. When I say treated conservatively, I'm talking about making lifestyle changes, possibly medications to control hypertension if it exists, to not put more pressure there, and really working on modifying those risk factors that we looked at. However, if the aneurysm is 5.5 centimeters or larger, as in the case of my stepfather, surgical repair is required at that point. So regular appointments and monitoring up until that point, but when we get there, we've got to take a look at some surgical options. The two surgeries that we'll discuss are an OAR, or an open aneurysm repair, and this is done by opening the sac, inserting a synthetic graft, and then suturing back what's called the native aortic wall, or the client's own aortic wall. So it's called native. The picture on the right is an EVAR procedure, endovascular aneurysm repair, with grafting, and this is done generally through the femoral artery if it is in good shape and can handle this. This is done for smaller aneurysms, not very, very large ones like the picture I showed you at the beginning of this voiceover. They go in through the artery. Well, I'll tell you what, I embedded a video in that picture, so you can click on that and open the hyperlink. It's very short, but it shows you how the procedure is done. So again, I think it's good to know how the procedures are done, to understand the care that is required of us as nurses afterwards. So complications of this surgery include leaking from the graft over time. A dissection can occur. Clots may form, and probably one of the most serious ones is abdominal compartment syndrome, which can ultimately cause a rupture of the aorta and often results in death of the client. Also to consider post-op is that the client will probably be in ICU for a day or two for really close and careful monitoring. Again, monitoring the renal status, ensuring that the graft is patent, which we can validate through effective distal perfusion. We want to have a good blood pressure, not too low, which can result in graft thrombosis, but not too high, because that can put undue stress on the wall of the artery and the incisions. We want to ensure adequate respiratory function, fluid and electrolyte balance, pain control, and good positioning. Usually clients may be supine immediately following surgery, and then can roll from side to side and then eventually get up out of bed. When clients are ready to go home, discharge teaching looks like this. Certainly no heavy lifting. We need to teach them reportable symptoms such as pain, which should be subsiding at this point, fever. Many of these clients return with infected grafts. And then we need to talk about lifestyle changes, again, in modifying those risk factors. So exercising, smoking cessation, healthy eating, and ensuring that medication is taken. Do clients have access to medications? We want to prevent any future vascular problems. Aortic dissections occur when there's bleeding in the lining of the arterial wall, and that lining, called the intima, separates. So you can see that there in the picture. It usually occurs in the thoracic or the ascending aorta, and in the ascending aorta, a dissection is life-threatening. There's a 90% mortality rate. These are commonly associated with poorly controlled hypertension, trauma, and cocaine use. So onset is usually sudden. It can be acute or chronic. In an acute stage, onset is sudden. Often it's mistaken for an MI, and it's early. It's difficult to diagnose this early on. It's usually you have to rule out all those other things like an MI. Clients may be pale, sweating, tachycardic. Their BP may be elevated, and sometimes it's different from one arm to the other. This is a good picture because it helps us to know what assessment findings or clinical manifestations we will see depending on where the location of the dissection is in the aorta. So up in the top in the aortic arch, or the thoracic area is another name for it, we're thinking about how the aorta feeds the head and neck. So we would be looking at neurological deficits such as altered level of consciousness, dizziness, weak or absent carotid and temporal pulses. The ascending aorta is the most serious, and remember that's where the highest mortality is. And here, because the ascending aorta feeds the coronary arteries, so we're going to see things like valvular insufficiency, diastolic murmurs, left ventricular failure, dyspnea, and orthopnea from pulmonary edema. The descending aorta, if the dissection is there, that feeds the periphery, and so we would see decreased perfusion to major organs such as the kidneys, decreased perfusion to the lower extremity, maybe decreased bowel sounds, decreased urinary output. So it's helpful to be able to look at this and think about all of those manifestations. Complications of an aortic dissection include cardiac tamponade, and this can be manifested by hypotension, a narrowed pulse pressure, JVD, and something called pulsus paradoxus. Now, pulsus paradoxus is a rapid drop in the systolic pressure during the inspiratory phase of breathing. Ruptured aorta is also a complication that's very serious, and of course death. If a client makes it to surgery, which often is not the case, our nursing care would be similar to that of a client with an aortic aneurysm repair. So you would take yourself back to slide number 9 of this voiceover and review those nursing interventions and the care of those clients, because it would be exactly the same.